في حاجة ثانية؟
Okay. Thank you, Professor Rasha, for your presentation. I'm greatly honored to attend the radio diagnosis conference, and I'm honored to be sitting beside Dr. Muhammad Sabri, Dr. Randa Abdallah, Nihad Osman, Professor Nihad Osman, and I'm greatly honored to call for Professor Minna Shalaby to present Pulmonary VQ Scan Revisited, What's New?
Good morning, everybody. My talk today will be a brief talk about pulmonary VQ scan, its new applications, just to draw attention that conventional nuclear imaging still has a role. Not only PET-CT is taking over, but still there are new applications for the pulmonary VQ scan. As you all know, VQ scan is the oldest non-invasive radiologic examination available for evaluating pulmonary embolism. It was initially used in human in 1964. This is the normal VQ scan. This is the ventilation images. As you all know, the imaging is posteriorly. So this is the left lung, and this is the right lung. These are the perfusion images, and as you all see, there are homogeneous tracer distribution in both lung fields with no perfusion defects. So this is a normal scan. This is a case of pulmonary embolism where there is a mismatch between the ventilation images and the perfusion images. There are segmental defects in the in the right lung as well as the left lung. Sometimes there are false positive cases of VQ mismatch. As this patient has increasing oxygen demands after shoulder surgery, the perfusion images show a large area of decreased perfusion in the left lung. But the chest X-ray images show that there is a retrocardiac opacity with an air fluid level consistent with a hiatal hernia that was confirmed by CT axial images. Another case with a known case of metastatic spindle cell carcinoma presented with dyspnea. Perfusion scan shows numerous areas of perfusion defects with this significantly reduced left lung perfusion. As you see, there is faint tracer uptake in the left lung. The CT confirms the presence of numerous metastatic deposits with no pulmonary embolism. Another case known IPF presented with dyspnea. It shows predominantly mismatched perfusion defects, most pronounced in the left lung. The CT shows corresponding areas of confluent fibrosis, no pulmonary embolism. So this led to that the European Association of Nuclear Medicine, that they recommended VQ scan. They recommended VQ SPECT CT, especially for perfusion. It allows even better anatomic localization with imaging findings that can be confirmatory for pulmonary embolism, or alternatively demonstrates an alternative cause that explains the patient's symptoms that mimics PE. This case is a patient of chronic thromboembolic pulmonary disease. The SPECT CT perfusion images show multiple scattered wedge-shaped perfusion defects, which was completely normal on the ventilation images. And the CT pulmonary angio confirms the presence of pulmonary embolism. So which is better, the VQ scan or the CT pulmonary angio? The CT pulmonary angio is now considered the most sensitive method of evaluating acute pulmonary embolism. It is faster, readily available, easier to interpret, and can sometimes provide an alternative explanation for the patient's symptoms in case where pulmonary embolism is not identified. This is an example for the value of CT pulmonary angio. This case, a patient presented with dyspnea. The ventilation scan demonstrates multiple perfusion defects in both lungs. The CT pulmonary angio presents the cause of this dyspnea. There is a large embolus in the right main pulmonary artery, but it also demonstrates an added value where there is a large right ventricle with the shift of the interventricular septum to the left. So the added value that it confirms there is a right ventricular strain in this case. However, the accuracy of CT pulmonary angio comes at the cost of increased exposure to ionizing radiation, especially to the breasts and the lung. But still, fetal radiation exposure in both in pregnant patients remains below safety level and is probably comparable for both studies. Here comes the advantage of the VQ scan over the CT in such morbidly obese patients. There is a degraded image in the CT pulmonary angio, whereas the lung perfusion scan is perfectly normal and shows no pulmonary embolism. So this is the value, one of the values of the VQ scan, that it is not affected by the morbidly obese patients. Let's take a look at this saying. The Greek philosopher Socrates, once upon a time, he said, "Speak so I can see you." So can anybody guess what this has to do? To save time, if we apply the saying to functional imaging, we can say that functions, so can I see you. This is the basic concept of molecular imaging, and this is the idea of the coming quantitative lung scintigraphy. It is the basics of all the applications of the gamma camera techniques nowadays. The VQ scan is a valuable clinical tool for determining the functional contribution of each lung or a specific anatomic area to overall pulmonary function. It also provides physiological functional information, such as in congenital heart disease. The asymmetric pulmonary perfusion is a predictor of outcome and exercise capacity in patients with complex congenital heart disease. Right to left shunt is commonly seen with congenital heart disease. A perfusion scan with whole body images has the unique ability to quantify the degree of shunting by comparing the counts in a row drawn over the lungs compared to the counts in a row drawn over the rest of the body. This is a case of a corrected corrected pulmonary atresia, and the patient has anatomic right to left shunt. Besides tracer deposition in both lungs, in both the anterior and posterior images, there is tracer deposition in the brain and in the kidneys and in the thyroid, in the bowels. So the 19% of the blood flow went to the lungs, and while 81% went to the systemic circulation. So the quantitative lung scintigraphy here confirmed the presence of anatomical right to left shunt, and it quantifies the degree of shunting. Also, it is valuable, the quantitative lung scintigraphy is valuable or crucial for estimating the expected remaining pulmonary function after puncture or total lung resection for lung cancer. SPECT is also used to plan the radiation fields for lung cancer to preserve the most functional zones of the lungs. This is a workup of a lung cancer patient. The perfusion SPECT-CT allows quantification of the pulmonary perfusion of each lung lobe to determine the expected residual lung function after resection. And it appears in this color in this pie chart or in such a table. Also, it is valuable in pre-surgical planning for lung volume reduction surgery to resect the less functional portions of the lung and allow improved respiratory mechanics of the spared lungs in a patient with COPD. Such as in this case, there is a pre-surgical evaluation with perfusion scan in this patient. There, as you can see, this is the most functional parts of the lung. Both upper lobes show tracer deposition, while both lower lobes show the increased, there is faint tracer uptake in it, which confirms that both lower lobes has predominantly emphysematous changes, and this is confirmed by the CT images. So when they plan for surgery, they will resect lower lobes and save the upper lobes. Before lung transplantation also, it has a value. In cases of bilateral lung transplant, the less functional lung will be resected first to avoid cardiac bypass during the procedure. And also after lung transplant, the bronchiolitis obliterans is the main cause of chronic lung allograft dysfunction. And even though the higher resolution CT is critical in evaluation, lung scintigraphy can demonstrate early functional changes before any detectable anomaly. This case, the patient has a worsening pulmonary function after bilateral lung transplant 3 years earlier. The ventilation images show patchy areas of decreased ventilation with several areas of xenon retention more in the left lung. The perfusion images show matched patchy decreased perfusion more on the left. This is consistent with bronchiolitis obliterans. And the CT confirms the diagnosis. There is mosaic attenuation in the upper lung lobes and diffuse areas of air trapping bilaterally with associated bronchiectasis. Now we will come to some accidental lesions. They are very interesting. They are detected at lung scintigraphy. Tumor microemboli or lymphangitic spread can mimic the pulmonary embolism. However, they have a special pattern. They are smaller, more numerous, more peripheral, and bilateral, and homogeneously spread throughout the periphery of the lungs. They result in the well-known contour mapping appearance. As in this case, the ventilation is completely normal. The perfusion shows this peripheral, small, mismatched defects, giving the contour mapping appearance. The corresponding CT image confirmed the presence of thickened interlobular septa, which is suggestive of lymphangitis carcinomatosis. Also, the superior vena cava obstruction can cause shunting of blood from systemic veins to portal system, mainly through the internal mammary, to the paraumbilical vein, then to the left portal, then to deposit primarily in segment 4. This results in the famous quadrate sign or the hotspot sign in the technetium sulfur colloid images. In the lung perfusion images, this is a case of superior vena cava obstruction in a patient with fibrosing mediastinitis. The VQ scan shows absent perfusion of the whole left lung, as you see. The whole left lung, the left lung shows no perfusion. So this is, the left lung shows absent perfusion, while in the ventilation it is much better. This is caused secondary to multi-vessel occlusion by fibrosing mediastinitis. And there is a focal increased activity in segment 4. This is a zoomed image. There is an increased focal activity in segment 4 of the liver, which is known as the hotspot sign. And this is also seen in the corresponding contrast-enhanced CT image. It shows the deposition of contrast in the segment 4. Air leak, which can result from central bronchopleural fistula, is a serious complication of many diseases and surgical procedures and is challenging to localize at image. Ventilation scan can show tracer leakage in the pleural space at the site of fistula. The perfusion scan shows absent uptake in the corresponding location. This is a case of bronchopleural fistula. As you see, there is xenon accumulation in the right upper lobe here, and the corresponding perfusion scan shows absent tracer. So this is the site of the bronchopleural fistula where xenon could escape and reach the pleural space or the area of loculated pneumothorax. So the conclusion is that VQ scan has been used for many years, and now it's helpful in investigation of several diseases. Recently, there is a comeback for the VQ scan because of its new application in the quantitative assessment of many lung disease. Thank you.
Thank you, Dr. Menna, about your excellent presentation. بس في نقطة حضرتك قلتيها أنا مش هقدر أعديها. حضرتك قلتي ال VQ scan may be helpful in pregnant patient with breast cancer. This is a very important question because انا شفت مراكز في ايطاليا بيعملوا بيت سي تي للبريجننت وومن عشان فور ستيجنج، لان احنا بنيجي في اول تريمستر او حتى يجي في ثاني تريمستر ما بنعرفش البيشنت دي اني ستيج، وللاسف ريجكتد من السي تي والام ار اي بيكوز اوف كونتراست انهانسد، بيبقى الريسك عليها، والاكس راي بيبقى اكسبوجر للفيتس. لا كنا في المؤتمر بتاعنا كنا معانا خبير من ايطاليا، هم عاملين سنتر اوف اكسلنس لتريتمنت اوف بريست كانسر ويز بريجننسي، وبيعملوا بروتوكول بيت سي تي بليس اكسبوجر للسي تي، بلو اكس راي اكسبوجر، وبيحقنوا اف جي قليل عشان يشخصوا البيشنت اللي هم عندهم بريست كانسر ويز بريجننسي. طبعا دي مهمه جدا، احنا بناخد قرارات مصيريه في الحالات دي، يا ابورشن يا تكمل علاج يا اما تاخد كيموثيرابي، لان احنا we have a recommendation that we can give chemotherapy in the second and third trimester. فينفع نحط تعاون بيننا كوحده يعني اورام وقسم الاشعه ان احنا نحط بروتوكول سيف يتعمل بيه البيت سي تي للمرضى البريجننت، ازف ان هي بتقول لي في كيو سكان وده سكان في اكس راي وفي اف جي السيف in the patient with
it is much safer than CT pulmonary angio يعني so far، وحضرتك الانجكتد دوز مش كبيره، واحنا بالنسبه للفيتس الدوز اللي هياخدها هم لقوها comparable من اللي هتوصل له من السي pulmonary angio والفي كيو سكان.
ده نفس الكونسيبت اللي هم كانوا الطلال اللي بيتكلموا بيه، ان هم بيعملوا بروتوكول لو اف جي ولو اكس راي للبيشنت هم بريجننت.
بس هو الفي كيو سكان مش اف دي جي حضرتك، احنا بنحقن حاجه يعني زينن او يعني هنا مش زينن، ما بنشتغلش بالزينن بس بنشتغل بحاجات تانية، وبنشتغل بالام اي اي اللي هو ماكرو اجريجيتد البومين، يعني هما مادتين مشعه، واحده للفنتيليشن وواحده للبرفيوجن، مش اف دي جي.
طب حضرتك شايفه البيت سي تي ان جنرال از سيف during pregnancy لو احنا عندنا
لو فيتال دوز بصراحه ولا حاله، يعني ما جالناش الجرأه ان احنا ما جاتلناش اصلا،
مش بنبعت اصلا
بالظبط، ما جالناش ولا حاله بصراحه.
يعني كيب الفوكس وممكن نتكلم فيها ان شاء الله later on
ان شاء الله باذن الله.
هو اعتقد الاكسبوجر في السي تي بالمونري انجيوجرافي 5 اضعاف الراديشن اكسبوجر في الفي كيو سكان. يعني دي انا كنت قريتها، يعني 5 اضعاف، يعني سي تي بالمونري انجيوجرافي بتعرض العيان للراديشن طبعا 5 اضعاف الفي كيو سكان.
بس هو البالمونري انجيوجرافي انجز، يعني ساعات بيتعمل بسرعه اسرع شويه
اكيد يعني لكن لو حضرتك بتتكلم على بريجننت وومن وشاكين مثلا في بالمونري امبوليزم
فور ستيجنج نوت فور فور ستيجنج، احنا طبعا للاسف ما بنعملش يعني في بروتوكول بينا يعني الاسم ان احنا ممكن نعمل هول بادي ام ار اي وزاوت كونتراست فور ستيجنج، لكن ستبقى برضو الاف دي جي فاليو في القصه دي مهمه جدا، بالذات الناس اللي هم في الايرلي بريجنسي، لان هم في اللي بريجنسي بنلاقي البريست هايبر دنس والفيتس طبعا واخد ابتيك عالي جدا، فبتبقى ان اكيوريت. هي ميزته انه يتعمل في الفيرست تريمستر قبل ما يحصل التشينج اوف بريجنسي فور ستيجنج، وده مهم جدا جدا في القرارات بتاعه العلاج، يا اما تو ابورت او تكمل، فبيبقى فعلا يعني تايم تشينجينج. It's honor to me now to present زميلي وصديقي أستاذ الدكتور يحيى عمر حسين. We are sharing in many cases with nutrition. Why do we use need nutrition plasma in therapy